Good afternoon, everyone. Welcome to this month's AFPHM webinar. Today we have Dr. Marianne Gale talking about oral health in Australia. As always, please type your questions into the Q&A panel and all questions will be answered at the end of the webinar. Thank you. I'll now hand it over to Dr. Marianne Gale.
Thanks, Terence. And hi, everybody online. So I don't know how many of you there are, but I'm here in North Sydney, New South Wales, with some of the trainees here in the room with me. So I think we've got the next hour to have a discussion about oral health in Australia. And I think I hope it's an interesting topic for you. It's one, I think, as public health physicians or in training, or even as doctors, actually, we probably don't know a lot about oral health. If your medical school days were anything like mine, we had the first year or so with dental colleagues, and then everyone went their separate ways, and we didn't really think a whole lot about the mouth or the teeth in the rest of medical training. But I think oral health really raises a lot of very important public health issues and concepts that I think are very relevant to public health physicians. So we'll get started. So firstly, why is oral health an important public health issue? And this is not an exhaustive list, it's just some of the points that I think are relevant as to why this should be important for public health physicians. So firstly, poor oral health is common, and we'll go through some of the figures later. It's an important cause of morbidity in children as well as in adults. And oral health conditions are largely preventable. We know what good basic dental hygiene does. We know the importance of fluoridation. We know lots of the risk factors like sugar consumption, tobacco smoking, lots of things that cause poor oral health, and we'll talk in more detail about those. But, it is largely preventable. Oral health is an important contributor to rising healthcare costs, and as I'm sure probably all of us from our own personal experience will know that how much of an expense dental care is, particularly for the individual, so the out-of-pocket costs. It's an important cause of poor quality of life. Dentures are expensive, for example. Lots of older people, if you don't have good fitting dentures, it's a serious impact upon your ability to function socially. No one likes the dentures to fall out or to not have dentures fitted, not able to eat proper nutritional foods. And that's a very real problem for lots of people in our community, and particularly for the ageing population. There is a strong relationship between oral health and health inequalities and social inequalities. And that's something that we'll see in the data, but I think also very important for public health because we work a lot in health programs for people from disadvantaged communities. And so it's really important as part of those activities to think about opportunities to also address oral health needs, because it is really important. And oral health really should be better integrated with general health care. And this is not just an issue for Australia, this is a global issue and something that the WHO wrote about back in 2005. But not just in medical training, as I talked about earlier, but I think that sort of divergence of the mouth or the teeth as being separate almost from the rest of the body is something problematic for our health system, because why should we have different systems for our body, the rest of our body, but separate for our teeth and our mouth? So on the next slide, so the objectives really for our session this afternoon is to briefly talk about epidemiology of poor oral health, the risk factors for poor oral health, the relationship between oral health and some key medical conditions of public health importance, and then to have a discussion about the funding and delivery of oral health services in Australia, because I think it's something that's not really well understood, and I think as public health physicians it's important to have an understanding about what the key issues are. So it's important to be aware that Australia does have a national oral health plan. So this is the National Oral Health Plan 2015 to 2024, Healthy Mouths, Healthy Lives. So if you're particularly interested and want some extra reading of a night time, I encourage you to have a look. This is just a snapshot of the outline of the plan at a glance. And it's basically the national goals are to improve oral health status, so unsurprising. But right up the top there, you can see is about reducing inequalities in oral health status across the Australian population, and that's a really key feature. The guiding principles, I think, are good ones. So population health approach, and acknowledges that there's lots of population-based interventions that we can undertake to improve oral health. While going to see your dentist regularly is important, it's not the only thing that we can do to improve population oral health. Proportionate universalism, which I had to kind of look up and remember what that means, but essentially it's getting towards the concept of equity, that you make care universally available, but you have to deliver care that is proportionate to the need. And some people have greater needs than others, and our service should be able to deliver and be cognizant of that. So the third guiding principle there is about appropriate and accessible services, and I think the access component is a particularly key one, noting some of the barriers, particularly cost. And then the fourth principle there is about integrated oral and general health, which is something we've already touched on, and the importance of doing that at every opportunity. Foundation areas we won't go through in detail, but just to draw your attention that even at national level, there is that recognition of priority populations. So particularly Aboriginal and Torres Strait Islander people, people who are socially disadvantaged or on low income, people living in regional remote areas, and we'll look at some of the data around that, and also people with special health needs, so particularly people with disabilities or with people with mental health. And again, dental care is one of those things that often reflects a person's means to navigate the system and be proactive about their health. So briefly, and look, there's lots we could talk about, but I've tried just to put the most salient points together to give you an overall understanding about some of the issues. So dental caries, as we know, decay, it's the most prevalent chronic disease worldwide, even though we often wouldn't think of it that way. So greater than 90% of Australians have experienced dental caries at some time in their life. Probably many of us here have had that. And so the measure that is used to measure the rate of caries in the population is usually this one, which is DMFT, so it's decayed, missing or filled teeth. And so in dental or oral health surveys, that's the indicator that is generally used, so DMFT. So something just to be familiar with. So looking at children, for example, in the next slide, this is a graph of data on the average number of decayed, missing or filled teeth in Australian children over quite a time period. And you can see there that, rates back in the 70s, I think, haven't got my glasses on to see the screen, were quite high, but over time that has dropped off. But what's interesting is that sort of kick up that's been happening in the last few years. And I'm sure you could probably speculate as to why some of that is. I think some of our changes in dietary habits, so sugary drink consumption, for example, the foods that children consume has changed quite a lot over the last 20 years in availability of fast foods and foods that are not necessarily good for kids, and hence the importance of the overlap between childhood obesity interventions and oral health, because there's a lot of common and overlapping risk factors. And the other thing to consider is also the increasing number of people drinking perhaps bottled unfluoridated water compared to the water out of the tap, which is fluoridated. So these are some of the challenges in the current environment that are important from on a population level. And it should note also that there is poorer oral health status for Aboriginal children, who have about 50% higher rates of decay. Similarly for children from lower socioeconomic status, and similarly for children from rural and regional areas. And survey data over quite a long period of time has shown that those general themes emerge. So in terms of the oral health of adults, so in general about 3 out of every 10 adults have untreated tooth decay. And similar to the children, poor oral health status is related to, again, the same sorts of things that we can see is what's driving it. So low socioeconomic status, higher rates in Aboriginal people, and poor oral health in rural and regional residents. And in addition, some of the key groups, people with disabilities, because you could imagine, going to see your private dentist, if you've got a severe disability, it's very difficult to actually access that and all the arrangements that need to be in place for you to get the oral care that you need. People with mental illness, for example, have, I think it's about threefold the incidence of oral health, of poor oral health, and the frail elderly as well. And we talked earlier about the example of dentures and that problem as our population ages. Oral cancer as well in adults is something important to bear in mind, and there are risk factors such as particularly tobacco smoking. Obviously, we know a lot about tobacco smoking in terms of lung cancer risk and its contribution to other cancers, but in an oral health frame, also important to think about the risk of oral cancer, and similarly alcohol, which carries a risk of oral cancer. This is a graph in one of the AIHW reports looking at the number of acute, potentially preventable hospitalisations per 100,000 population. And the data is a little bit old, and it's something to flag for oral health data in general. It's quite difficult to get quite up-to-date data. So this is a national problem and one that is being worked on, and there's jurisdictional groups that are working on better data collections for oral health, but it has been a challenge. So this is a graph on potentially preventable hospitalisations, and you can see that dental conditions are the third most common cause of potentially preventable hospitalisations. And that is to say that if there were interventions earlier, that child or that adult didn't need to be in hospital, for example, under a general anaesthetic to get a tooth extracted or an abscess drained or similar. So we already touched on some of the risk factors for poor oral health. So we're going to go through each of these in turn. So the first one, sugar intake, and it's really about free sugar consumption. Access to optimally fluoridated water is incredibly important. Toothbrushing, dental visiting patterns, alcohol consumption and tobacco use. So we're just going to go through and talk about each of these a little bit in greater detail. So firstly, sugar consumption is the main contributor to dental caries in all age groups. So again, you can see the overlap, not just with some of the population level efforts to address obesity and childhood obesity, but the really important impact this has also on your teeth and your oral health. So WHO has a recommended maximum intake of free sugars. So free sugars are basically sugars that a person or the manufacturer adds to food. So when you put your sugar in, or fruit juices and honey, for example. So it doesn't include the natural sugars that would be in fruit or in vegetables or in milk, for example. So the maximum intake of free sugars from the WHO is about 10%. So it should constitute about 10% of your total energy intake. So a survey of the Australian population showed only about 48% of adults met the, or actually, so 48% of adults exceeded the WHO recommended intake, 73% of adolescents, and 70% of children. So it's rather frightening, I think, the excess sugar consumption, not just for oral health, but for general health. So reducing free sugar consumption across the population really is a key goal for improving oral health. Okay, and hence the importance, and wherever we're doing health promotion activities or efforts to educate the community about diet and its relationship with chronic disease or with obesity, wherever possible, it's important to try and piggyback the messages about oral health as well, and vice versa. So the next slide, looking at access to optimally fluoridated water. And water fluoridation, as you're going through your training and when you come to exams, is something that you should, read about and be familiar with for those of you doing your exams. So the role of fluoride was first discovered in the 1930s, and it began in Australia in 1953 and has been gradually rolling out in different towns and different councils since that time. So generally, Australians born after 1970, which was when the large part of water fluoridation programs were rolled out. So people born after that time have experienced approximately 50% reduction in caries compared to their parents' generation. So it is really important and does have that population impact on dental health. As you are probably well aware, there remain pockets of controversy about fluoridation and concerns about the effects that it has on people's health. So this is something that the NHMRC has looked at over the years and more recently has been through another thorough review of the evidence of water fluoridation. So I won't go through it in detail. I'd encourage you, particularly those for doing the exams, to be familiar with the public statement that the NHMRC put out late last year as a result of the public consultation and their review of the evidence of water fluoridation. But the bottom line is basically that the NHMRC, after that thorough process, still recommends community water fluoridation as a safe, effective and an ethical way to reduce tooth decay. But of course, it has to be within the proper range. Otherwise, when it's higher than that, you risk some side effects, mainly fluorosis of the teeth, which is that kind of white staining, which mostly is minor but does cause cosmetic issues. Okay. So in terms, there is variation across Australia in the coverage of water fluoridation. So this is the graphic, and you can see there that variation. So ACT does the best at 100%, which is great. But ACT is small. However, well done ACT. Some of the other jurisdictions you can see there are less well covered, so notably Queensland and the Northern Territory. And it's interesting when you look at the prevalence data of oral health disease, there is it does correspond that often the rate of dental disease or caries in those contexts is higher, and so the lower coverage of water fluoridation may well contribute to that. So overall, about close to 90% of the Australian population has access to optimally fluoridated drinking water. So moving on to the next risk factor, which is toothbrushing. So I know every time we all go to the dentist, you get reminded of this. So clearly, it's a basic oral hygiene measure to reduce dental plaque, where bacteria can live and basically contribute to caries. There's good evidence for using a fluoridated toothpaste to reduce caries. And what many people in the community may not know is that toothbrushing should really begin around 6 months of age or when the first tooth appears, and continue for life. However, so despite that, advice, which is kind of old advice, there's still difficulties in getting the population to actually do it. So from survey data, we know that only about a half of Australian adults and 2/3 of children brush their teeth twice daily. So the frequency of visiting your dentist or having a regular checkup is also really important. And they're key to prevention and early detection of disease. So children should really have a first visit to the dentist before 2 years of age. And again, many people in the community might not know that. And there's lots of young children who never go to the dentist. So for example, from the National Child Oral Health Survey in 2012-14, this published data showed that only about 56% of all children visited a dentist before their 5th birthday. And it was even less for young Aboriginal children. But children from higher income households were more likely to visit. So again, through all the indicators that we look at, you see these social drivers and these other determinants of oral health, not just status, but also service utilisation. And yeah, so around half of adults have not had a dental checkup in the last year. I'm getting close to the year, so I'm not quite one of them. So alcohol and tobacco use. So we talked about them briefly at the beginning. So they're particular risk factors for oral cancer. Alcohol use is more about longer term consumption. So it's not really about, single occasion risky drinking. You wouldn't expect it to be, but it's really about chronic use over a long period of time, even not in high volumes, but just long-term use. And tobacco, not just about cigarette smoking, and probably some of those are less relevant to the Australian context, but I'm sure we've all been, in travels in different countries where people chew betel nut or chew tobacco. So similarly, really puts them at risk for oral cancers as well as gum disease. So really any inhalation as well that burns the throat is associated or a risk for oral cancer. So briefly, we've talked about these common risk factors, so sugar consumption, diet. We didn't talk specifically about sugary drink consumption, but wrapped up in that free sugars, but it's really important. So the messages about drinking water, the same sort of messages that we give related to childhood obesity are really important in the oral health context. We know about oral manifestations, obviously, of systemic conditions, but there is also evidence of associations of overweight and independent associations between overweight and obesity with dental caries and periodontal disease, and similarly with diabetes. And so that evidence is still being generated, but there's hypotheses around the chronic inflammation, for example, that can occur in chronic dental disease that may have a relationship with chronic disease. And so increasingly, it supports the argument about having a holistic approach to the person and the impact of oral disease on people's general health. Okay, so we're going to move on now to talk about the funding and delivery of oral health services in Australia. So important concepts to recognise, and that is firstly, that there is no Medicare-like system that provides universal access to dental care. I guess we've all grown up in going to see dentists ourselves. You just sort of accept that you'll pay for dentists. If you have private health insurance, they might cover some of it. But conceptually, it's interesting why in Australia, when Medicare first started, oral health was not part of it, and it's grown up separately through a different mechanism that's not in Medicare. So that concept that there is no universal access to oral health care is something key to understand. So approximately 85% of all dental care in Australia is provided by independent private practice dentists in some kind of fee-for-service arrangement, which will be what all of us, would encounter when we go for our 6-monthly or 12-monthly checkup. Around 15% of dental care nationally is delivered by state-based public dental services. And essentially, in each state and territory, the public dental service is a safety net system. So basically, in the absence of this universal access, in the absence of a Medicare-like scheme, what has grown up in states and territories is these safety net systems. And we'll talk a bit more in detail about them. And the Commonwealth has also historically funded some specific dental schemes, and they have kind of changed over the years. And so we'll talk a bit about the schemes that are currently in place. So thinking about who pays for dental services in Australia. So around 50% of people aged over 5 years have some level of private health insurance that includes dental. Will not be a surprise to you perhaps to learn that that percentage is lower amongst people with lower socioeconomic status, but it's also lower among people living in rural and regional areas. So it's an important concept, I guess, when most of it is done by the private sector and the only reimbursement that you would get is from a private health insurance. So nationally, our total expenditure on dental is large. So it's around the order of about 9 billion. It's difficult to get an exact estimate. The AHW publishes expenditure reports, which is the best estimate that we can sort of get around the actual expenditure on dental care. What's important to note is that different from other medical services, for dental care, individuals bear the majority of that cost. So approximately 58% of the total cost of dental care is by direct payments from individuals. And an additional 16% is, again, contribution from individuals through what they pay to private health insurance coverage. So as you can see, it's actually, really a considerable cost that the individual bears. So this is, result of one survey, and there's lots of surveys which show a similar figure, and that is around about a third of people report avoiding the dentist due to costs. So the next slide in this graph, this is from one of the AIHW reports. It's looking at expenditure on dental services per capita by the source of funds. So at the top line, so this is per capita, you can see the total dental expenditure. Under that is non-government, which is basically primarily the individual who bears the cost. And down the bottom, you can see the Australian government contribution and then the state and local government contribution. So that out-of-pocket cost concept, or the individual bearing the cost of care, is an important concept to understand in oral health. So thinking now about that 15% of the big picture, which is delivered by state-based public dental services, as I mentioned, they are safety net services, and that is they provide a limited range of basic dental care, plus some specialist access. There is no one model across all jurisdictions, so each of the jurisdictions have grown their state public dental services in slightly different ways. However, there are similar eligibility criteria across jurisdictions, however not the same. So for example, in some jurisdictions like New South Wales, all children are eligible for public dental services. However, in some other jurisdictions, there will be specific age groups that are eligible and more limitations around the children that can access public dental services. For adults, most jurisdictions have criteria that are based around concession card holder status. So people who have a pensioner concession card, a Commonwealth healthcare card, other kinds of concession cards, and they may look slightly different for different jurisdictions, but in general, that is the eligibility criteria. So for people to access the public dental service, they need to show evidence of their eligibility to be seen in the public system. Co-payments are generally charged to patients in most jurisdictions, with the exception of New South Wales. So here we don't charge any patients co-payments for dental care, and that's the same in Queensland and the Northern Territory. So the other jurisdictions have a co-payment schedule, which are very different across the jurisdictions. And I mention all this just to say, like, we don't have an equitable national system. So even for this very disadvantaged group, concession card holders, depending upon the state where you're in, you may or may not have to pay, and you may or may not have to, well, what you will pay will differ. Waiting lists can be long, especially for adults and for specialist care. So some patients, it's not unusual to wait, more than a year or 2 years or 3 years. Yeah, sometimes even longer in rare cases, which is really not good. States receive Commonwealth funding via two pathways. The first is national partnership agreements. So I don't know if in your studies you've sort of talked about the Australian healthcare system. You might have come across the concept of national partnership agreements, but there has been one in place for dental, serial agreements since 2013. And the other pathway is through the Child Dental Benefits Schedule, and I'm going to talk about each of them in a bit more detail. But before we do that, this is just an example from New South Wales to show, I guess, the impact upon these schemes and what they've had on New South Wales public dental services. So in this graph, this is the number of New South Wales residents waiting for dental assessment and treatment over the period from December 2011 to March 2018. And the purple line on top there is adults waiting for treatment. the sort of orangey line is adults being assessed, the blue line is children being assessed, and the bottom line is children waiting for treatment. And so what you'll notice is that when the first NPA first commenced, for New South Wales, it was a big injection of additional money. And what had happened before that is that many public dental patients were on a waiting list, but just not being able to be seen in a timely fashion. So what happened when the Commonwealth NPA started is that suddenly we were able to get all these people off the waiting list, and they were actually getting care that they had been waiting for a long time, because there is this huge demand. But then what seems to have happened is that people then realised, oh, you can actually get, timely care or more timely care in the public system. And so since then, the demand has just grown. So it means that our waiting lists are longer than what they were before the NPA first started, but people are getting seen more quickly. But it's just grown the demand because there is lots of people out there in the community who haven't been able to afford dental care, and now this is a more realistic pathway to actually get care. So that's one thing to note. The other thing to note is the blue line for children, and you can see that's when the Child Dental Benefits Schedule commenced, and we'll talk a little bit more about what that is. But it's quite interesting to observe how when that scheme became available, it dropped the demand from public dental services, because now children could actually get access more easily to basic dental care. So these Commonwealth schemes have a big impact on the very vulnerable groups who are part of state-based public dental services. So the Dental National Partnership Agreement, so currently we're in the third agreement, and it's for the period from January 2017, and it will end in June 19. And basically the Commonwealth provides about $243 million to states and territories to deliver additional public dental services to those people eligible, so that vulnerable group. We're yet to know what's going to happen after June 2019, so that's an ongoing conversation that's happening at the moment. So coming to the end, this is a bit of detail about the Child Dental Benefits Schedule. So this started in January 2014. And essentially what the scheme is that it provides $1,000 to eligible children to be spent over 2 calendar years for basic dental services. And there's a list of eligible services that can be provided. And eligibility is defined by essentially children who are within Family Tax Benefit A. So they're the kind of criteria. So it's means-tested access, basically. So nationally, there's approximately just over about 3 million children who are eligible to receive, be eligible for the Child Dental Benefits Schedule. And each year, just over $300 million is claimed under this scheme. But what's interesting is that it's actually been underutilised compared with the demand that's out there. And it's interesting, given that it is there and we want to actually see some of the most vulnerable children actually use this benefit, which is there for them. What's interesting, and I think it's an interesting demonstration about how when you have these schemes, how important it is to promote it to the population for whom you want to really benefit from it. So the graph on the right, you can see is the uptake by CFA decile, okay, where 1 and 2 and 3 are the most disadvantaged, and the 10 up here are the most advantaged. And the green, or the dark green, is the children who are not accessing the CDBS, and the blue is the children that are accessing. So what's interesting is that there seems to be a fairly similar proportion across all deciles of the children that are accessing the CDBS. A bit lower in the 10th, which is as you'd expect and what you'd hope. But I think what we'd really like to see is more of the blue in the lower CFA indexes, because really this is a great opportunity, and we know, given the data that we've looked at about the disproportionate effect or burden of poor oral health on children of low socioeconomic status, we'd really like to see, I guess, a disproportionate uptake in those lower CFA categories. So it's a good example, I think, when you have these sort of schemes available, how important it is to target them effectively. So it's already, a means-tested scheme, but even within that, you have a level of advantage and disadvantage. And so getting to the most disadvantaged in our communities often is more challenging, but something that is really important to do. So I'm going to end there. So that was a bit of a tour through some of the key epidemiology related to oral health, a discussion of some of the risk factors related to poor oral health, and then hopefully to give you an overview about some of the broader contextual issues around how oral health services are actually funded and who pays, and then how they're operationally delivered. So happy to take any questions.
Thank you, Dr. Gale. A reminder to anyone with questions on the webinar to please use the questions pane to submit your questions.
So Terence, I just click on the Q&A button, don't I?
Yes. Currently, we do not have any questions submitted at the moment.
Okay. Anyone in the room have questions?
I have a question. So you've got access for those who are at the extreme end of poverty, really, so access to healthcare cards, and then you've got people that can financially afford to go. But what about that huge group down there that are more likely to have significant dental disease that would cost somewhere in the vicinity of $1,000 or more? Is there any way for them to access anything when it's financially not feasible for them to actually afford it themselves? There's no way they can access.
Yeah, that's a really good point. So I guess that kind of working poor, I suppose, in the middle, who are not eligible for the concession cards to make them eligible for public dental care, but neither necessarily, even if they do have private health insurance, as we know, some dental care, you don't get a lot of rebate necessarily from private health insurance. So you're right, there is nothing apart from their ability to pay.
What about like the GP chronic care plans where you are able to access some funding? Are you able to use that for chronic dental disease at all, or that's not even an option?
No, there used to be a chronic disease dental scheme some years ago, before the National Partnership Agreements. And basically that was along those lines. Yeah. So for people with chronic disease, I can't remember the exact detail, I think it was about $4,000 over 2 years perhaps, but don't quote me on that were eligible for people where the GP said it could be part of a chronic disease management plan. So that was in place for a number of years. However, that was closed, and one of the challenges was it's hard to often manage overuse. And so while lots of people with chronic disease did get good care, the budget blew out for that scheme very considerably. And ultimately it was closed for that or for other reasons. And so the National Partnership Agreement was one of the schemes that then followed the closure of the chronic disease dental scheme.
Yes. Can I ask, it's actually similar to one of those questions. Like, is there any movement, or historically have there been any efforts to try and get a Medicare-like scheme or get dental work included in a publicly funded scheme? Or can you see it happening at any time in the future?
Look, that's a great question. Obviously, it's a very, providing dental care has become very expensive. It's for discussion, and lots of people write about this, about whether we do need it to come into Medicare. Whether that will happen or not, I don't know. There have been some recommendations from some reviews in the past that have put forward a Denticare-like scheme, but we haven't seen that yet. Okay, so we've got some questions on the. Okay, so there's one here about, is any move to have dental items covered by the MBS? So we've already talked about that one. I wanted to check what you recommend is done to check a dentist's work, clinical case review, peer review, what is best practice? Okay, so this goes, I guess, to the quality of care. I think it's a great question. Unlike in medical services, where increasingly there is a focus on safety and quality and collection of process of care measures and outcomes and comparison against similar facilities and similar surgeons, for example, and benchmarking of performance and transparency of hospital performance. That same move is yet to be made in the dental space. So as we talked about, the majority of dental care is delivered by independent private providers. There's no mechanism currently for public reporting on, quality indicators or outcomes of dental care, either from the private. In the public system, in New South Wales, we do have some level of reporting on our website, and we're, working on having even greater transparency once our IT and data collection systems allow us to have even greater transparency on, for example, the proportion of patients who are waiting within clinically appropriate benchmark times. So that's something that we're actively working towards, and I know other states and territories are similarly doing that. But there's no, at the moment, there is national work looking at outcomes and, suitable indicators for oral health. As yet, there's no real mechanism for transparent reporting of outcomes across both the private and the public sector. So we have a question from Candace. So do you have any role in the investigation of clinics if there is a concern that a patient has acquired a BBB during a dental procedure? Okay, so I personally have obviously been peripherally involved in those kinds of investigations, but not directly. However, probably all of you in different states and territories will know that this arises from time to time. So usually those investigations are managed cooperatively between oral health and health protection to investigate the risk. So no, I haven't been personally, but yes, it is a very important issue, and it is some of these procedures are risky, and the whole processes around sterilisation and are all really important. And there are discussions about the regulation of private dentists and the requirements around good practice and proper sterilisation processes and so forth. So only the health ombudsman would be the pathway.
The earlier question,
clinical outcomes. Yeah, look, to be honest, I'm not really sure about what role the health ombudsman would play. Just currently, the systems are not necessarily in place to actually define, which quality indicators are nationally accepted that we would want to report on publicly, or, in what form, how could that be collected from the public sector, how could that be reported from the private sector. So just a lot of those basic sort of data collection systems and the foundational systems to be able to do that are not necessarily in place across the board. They are in pockets and in some public dental services who've set them up, but not necessarily everywhere. Okay.
Is there much of an evidence base to what dentists do? So taking x-rays every 2 years and all those things are quite expensive, but I'm not quite sure what the clinical benefit of such an expensive intervention would be. Is there an evidence base for a lot of the stuff they do?
Well, I'm not a dentist, so I'm not sure the ins and outs of their procedures, but I think it's an important issue because I think the knowledge imbalance is even greater probably in dentistry between the dentist and the consumer, even greater than it is in medicine, I think. And obviously that's something that we battle with in medicine, is about how to equip the consumer with sufficient information to make informed decisions about their care and the evidence base and the risks or benefits of following one pathway of treatment versus another. and that's something that in medicine there's a lot of work being done on. I don't have visibility of the entire breadth of dental practice, but it's not something I've observed in dentistry. And even from personal experience of going to the dentist, if they tell you need a filling, what do I know? You just have to say, okay. So you would hope that they do follow evidence as good clinical, good health practitioners, as you would hope any health practitioner does, and provides you with the care based on best current practice. But I think the ability of the consumer to know that is quite difficult.
Yeah, so potentially producing a piece of work or something that looked at the actual evidence base and what you needed and when could help bring down the costs if then consumers understood what the evidence was behind a 2-yearly X-ray and the fluoridation treatments and all the extra bits that you get given that obviously are going to drive up the cost of your interactions. And you could bring down even the private costs of dental if it was information that could be accessed by the consumer, and then they could have a say in whether they have these things.
I think it's a good point. And look, there may well be over-servicing, but it's hard to have visibility of that.
How should New South Wales Health move forward?
What do you mean, Anthony?
What can the state do in this situation?
Well, there is a commitment to providing access to as many people as we can who meet those eligibility criteria, and providing a timely service and a service that is of high quality and evidence-based and consumer-friendly. And there's lots of work going on in New South Wales, for example, to make our call centres more consumer-friendly, rather than, have people wait online, on the line for half an hour. People who already potentially, might have complex lives or, be in pain. So how do we make our services more consumer friendly? So there's that commitment to the services that we already deliver, and about continuing to improve our efficiency in delivering care for some of those things that Laura mentioned. Have we got the pathways right? Are we seeing people really only when they need to be seen to actually have the impact? And are we appropriately risk stratifying people so that we see the ones who really need to be seen on a regular basis with a preventive focus, and perhaps not so much the others? In terms of the broader picture, I guess what would be great is if we had some sort of longer term understanding of what funding arrangements would look like, so that it would support the sustainable delivery of public dental services. And obviously we engage quite a lot with the private sector, because, as I think many other states and territories do, because we're not able to see the volume necessarily in-house. So there's, at least in New South Wales, and I believe other states and territories have it as well, voucher schemes with the private sector. And that can actually be a large proportion of the activity in many of our districts. So, for example, anywhere between 20 and 40% of all the activity is actually for patients who are given a voucher to see a private provider. And that's a really good thing. And it can be really important, particularly in rural areas where you want to actually maintain a private provider in a small town. And so enabling, the activity that comes from the public service to actually give patients to the private provider to remain there and viable and be able to service the community is really important. So, the public and the private do work together quite a lot. But I think the certainty of funding is a really important thing. Okay. So if there's no more questions, we might wrap up. So thanks everyone for your time, and I hope it was useful and gave you some of the basic knowledge about how public dental services and oral health services more broadly in Australia work, and what some of the key issues are, and also some of the important overlaps between oral health and the rest of public health. And I hope going forward in the various bits of work that you do, you will try wherever possible to integrate oral health messages so that we don't continue to work in silos for, other aspects of health and keep oral health as something entirely separate, because there's lots of population-based interventions that can be equally beneficial and synergistic. So it's really important to find those synergies and to harness them in the course of your work wherever you can. So thanks everyone, and I'll hand back to you, Terence.
Thank you, Dr. Gale. It was a very good presentation. If no one has any more questions, I think that wraps up today's webinar. I would like to thank Dr. Marianne Gale once again for her time. Thank you.
Thanks, everyone.